I think everyone seemed to have a good time this afternoon, and looking around the various groups, I thought they were going very well. And now we get to hear the exciting outcome of this. We'll start in the same order as they were listed in the program. And so the first one will be Group 1. This was the leader was Dr. Clark. Ah, there he is. he was trying to hide. I could see it. Oh, okay. John, they told me that there was this...
We're all behind you, John. That's right. Way behind.
John, they told me that there was this little invisible trapdoor here that if I punched a button, you could go down through the floor.
The sharks with the lasers on their head. All right, well, can we move that over here? Sure. I didn't have the luxury of getting it on a computer like some of our other teams did, so we had a great time, actually, and for all of the anticipation and anxiety that I was facing coming into this, so we really had a wonderful time. We had a great group, very interactive. And just to start off with, we were tasked with looking at the vision for space exploration, and we took a scope beyond just what our current national space policy strategy is. And we looked at kind of a big picture strategic view of things. And obviously one of the things that we would have to face would be to look at the hardest situation would be a Mars mission, planetary surface exploration, some lengthy period of transit, 6 to 8 months, some period of time on the surface, and then a similar period of return. So about a 30 to 36 month mission. Obviously you have the comm delays, the resupply and abort concerns that will challenge us to an extent that we've never really experienced before because we don't operate in that kind of environment. We looked at a kind of a broad spectrum of things that could be addressed. And these are nothing new, but right now we have selection and retention and assignment standards that focus on a select-out process to remove pathology in the selection cycle for astronauts. A select-in posture, not fully implemented, but to a certain extent there is crew selection and there is trying to pick crew that have the most likelihood for success. But it's clear that we need to be moving more towards a functional criteria and a health criteria as opposed to just a disease state criteria. And that is something that is in works, with the whole standards to deliverables area, but it's certainly in its infancy. One of the things that came out were things that we could do to implement a successful Mars base and then potentially a outpost and then continuous habitation. And one of those, which I heard other groups say too, was to use the platforms that we have available, like ISS as a test bed for the microgravity phase, and the lunar environment as a test bed for Mars, because we really have very limited experience in partial gravity with the Apollo missions. And an idea that Dr. Young had come up with was a Lunar Physiology Lab to study the specific exploration tasks that you would need to evaluate, much like we do in an analog environment. So the moon becomes an analog for Mars. Great idea, and that's currently not in the posture for the vision for space exploration. It's all about doing planetary science, but certainly we should make every effort to try to create a system that looks at evaluating countermeasures for Mars using the lunar environment. And obviously we'd have a similar component, which would be the lunar outpost clinic. So you'd have essentially the space medicine and the adaptation and countermeasures and environmental physiology groups doing work on the moon. To expand our knowledge gaps, we really need to look at the Apollo data. One of the things that was raised is the lunar dust toxicity, and we've only had 12 astronauts on the moon, and one of the concerns that's been raised is what does the lunar dust environment do? And one of the ways to do that is, as these folks pass away, is to do a very targeted studies on their pulmonary system, and also use the lunar dust in animal studies to study the toxicity issues that we would face when we send crews back there. So those are some things that we could do as we come to some useful recommendations. One of the things that I thought was really intriguing in this group was to implement a concept of space bioethics. And what that means here is that we're going to be faced with so many tough ethical questions, and we've already had this discourse at NASA with the appointment of an ethics advisor. We've had ethics seminars, but really to start targeting and raising the scenarios that we'd face for lunar and Martian outposts. So develop scenarios and then run through the what-ifs. And there was quite a few suggestions on issues that would be raised here, such as, do you abort a mission with a medical problem versus continue the mission? Do you use up your medical supplies for a crew member and then limit or completely eliminate the possibility for any subsequent crews to get treated? So there's a huge number of ethical issues, and perhaps one of the biggest take-home points from this group is to establish an active program for space bioethics. In fact, maybe we can even go to an ethics school and see if we can get a PhD candidate to take on that task, because it would really be fascinating to go there. The long pole in the tent is behavior and performance and radiation, but a huge knowledge gap, which probably will be covered in some of the other groups, is the medication issues in space. We have virtually very limited insight into what space pharmacokinetics and pharmacodynamics are. But given the transition to an individualized approach, one suggestion that was universally applauded was to really try to use the pharmacogenomics emerging discipline in our area. So it's individual targeted genomics and how those medicines work. And so that's an area that is really going to be one of those technologies that we think will be very valuable. As the mission planners and space vehicle designers have to approach the lunar and Martian architecture, a very fundamental concept is what is your level of care that you would expect to deliver in the worst case scenario? Would it be advanced life support for a cardiac case, for a surgical phenomenon, for a trauma? How long would you expect to maintain that level of care, and for how many individuals? Because that is going to be a prime driver for your logistics up, mass, and volume. So understanding those issues as we come to some consensus, if you have a crew of a certain size, how much level of care, what kind of training do the people that go in that crew have, the training procedures, equipment, and personnel all have to be taken into consideration. The new technologies that are coming out there, undoubtedly by the time we get to Mars, there'll be things that we haven't even thought of that will make it much more viable. We had a lot of interesting discussion on the number of crew for a mission that would require a great deal of autonomy, and the number was 6 to 7. The Russian colleagues had come up with a number 6 based on some of their studies, and interestingly enough, not unlike what Dr. Schuster said yesterday, was there should be an all-male crew, and they should be as homogeneous as possible, but that obviously is contentious, and the issue of the size of the crew, the composition of the crew training, a lot of those factors really should be considered as we start looking at ways to test that. One of the ideas was to provide a sense of redundancy. You'd have 2 missions launched, and you'd have an all-male crew and an all-female crew, and may the best ones win. And I think that's an interesting idea too. Or when they get to Mars, they have one hell of a party. There are a lot of, and that gets into the ethics issue. And I know we can't talk about the S word, but that's certainly something that's going to have to be taken into consideration. Artificial gravity has raised its head again. This is something, again, we have very little insight into partial gravity and artificial gravity en route on these long planetary transits may be one way to certainly to mitigate that. But there are a lot of issues there, and the debate is not yet squelched, although I've never heard an official posture from NASA Exploration Mission Systems Director, but it seems to me that it's dead. I just don't know who said so. We talked a little bit about the requirements for the crew. The consensus was that all the crew should have medical training, and that at least 2 should have advanced training, and that the areas of training should be diversified. Perhaps a surgeon, an anesthesiologist, a diagnostician, a therapeutics person, because this is going to be crucial to mission success. A tool that's being very actively looked at is the risk assessment tool. Its limitations are the assumptions and the data that you put into it. But this is something that we can do now. We don't have to go to the moon to do this, and we can start challenging this. And there's actually a very active program in life sciences to look at probabilistic risk assessment and certain tools that are going to be used by the mission planners, by the flight controllers, and by the crew themselves. All these phases have their unique and their own risk, and each of those you've got to target the concerns that you have in it from a medical, health, and habitability and behavior and performance standpoint. But it's clear that just the basic life support systems, the psychosocial interactions, nutrition, how do you carry that much food along with you? And the amount of mass that would be required to maintain just even a perhaps even subnominal standard of hygiene can drive your launch requirements and your up mass and volume to prohibitive levels. So those are things that we all thought of. Again, in another area that was felt is that, and this is speaking to the choir here, but we need a human-centric approach to vehicle design and mission architecture. And Constellation has left the train station, and for those of us who had followed it, that doesn't seem to be the central focus. I mean, it's an engineer-driven organization, and we all know that the human factors can be the thing that bites you. So we need to keep vigilant and pressing forward that case. So I guess I'll close up here, and if there are any questions, please refer to my other colleagues in the group. It was great. Thanks so much. Yes, John. And stand up, too.
Actually, I wanted to give you some, I hope, reassuring news, good news. On your first chart, you indicated that I think you said you thought that the artificial gravity story was at an end. In fact, for the Mars architecture study that's going on within NASA right now, artificial gravity is very much on the table. And in fact, I am leading a team that is producing a decision package to examine pros and cons for rotating vehicle artificial gravity. So that's not dead. And one of your second bullets was about the Lunar Physiology Lab. I hope you're reassured to know that the concept is alive in the lunar architecture, and that is the notion of like incremental buildup. We have asked for 2 space station rack equivalents in the lunar outpost for human physiology and medical research. Whether it survives all the inevitable changes in the concept as they evolve, I don't know, but it's in there now, and hopefully we can defend at least some fraction thereof.
Great. And I guess I will turn it over to Anessa, if there's no other questions.
I may have to recall you later.
Oh. Hers is nice and typed up, so. By the way, that's not my handwriting.
I put it here. I'm sorry. Oh.
I tried to erase it.
Now we will ask Dr. Sarkisan to read it to make it easier for everybody to understand. Yeah, but somehow among us we didn't find somebody who has any artistic talents, so we decided to write down on computer. Our group had challenged to prioritize needs, to fill knowledge and evidence base in space medicine. And to tell you the truth, the questions which were put for us turned out to be maybe too complicated for our group. It was a good group of very active people who tried hard to find the best answer to the question, and but maybe due to not enough time, because time was really short. It was 1 hour and 15 minutes before starting to formalize the conclusion. Somehow we could formalize and make some definition of and some conclusion of our work in which everything participated. And I will try to give you reports of what was the conclusion and what were the difficulties. So the very first question was formulated like, obtain approval and support to mine and catalog existing data. And the question or the topic is the continuation of the topic which was under discussion yesterday. And actually we tried yesterday very hard and didn't find a proper answer. But nevertheless, there was like two parts of the discussion. The first discussion, if there is anybody in the group or known to us who is against sharing, there was anonymously answer that everybody understands the importance of data sharing and necessity to find the way to mine, as you defined here, to find the way of taking in account of all difficulties, of differences in policies and rules and so on, nevertheless, to find the way of sharing the data, because that will be the great step ahead, forward, when we will combine our data, catalog them in standardized manner so that everybody can use it and bring their abilities in analyzing and making conclusions from this data. And they were suggested and discussed two ways to make it possible, this data sharing. One was discussed very heavily, but people who already I'm sorry, I don't know everybody. I can give even the names, but who has the experience analogous to the people who are working in occupational medicine and need also to analyze group data and so on. They said that the first approach, which was suggested, it means to code the names and then use the data as already anonymous data. You know, they are coded, but they are not personal. But it was accepted by all of us that this will not work because the group is too small, and the definition of the features of different subjects will be very evident. It will be difficult to code and then to do group analysis and so on. But the other suggestion, which was suggested by Dr. Canas, and what we discussed, and we found that it may be the way, it is to establish new rules for informed consent for cosmonauts to try to find their cooperation with the scientific community, that when they that in the consent it should be added the line that they don't object against the using this the data obtained for scientific community. How real it is, we don't know, but I think we will not know until we will not try to do it and to work with this community of astronauts and cosmonauts and so on. For us it looks much easier because our Russian cosmonauts, they used to be collective, and usually they don't mind very much, if it doesn't affect their career or somehow, will not make them look bad, they don't mind. And actually, for years we were doing, and I appreciate very much their help. Usually we consider them as the co-authors, as the co-investigators, and that's what is really true. They are not rabbits. They're doing this experiment. They're performing this experiment, and they don't mind using this for publication and so on and so on. But still, it is, and Ashot, can you read what was the I can read from here, but please do it for the auditorium, yeah?
Dr. Kozlowska is referring to
the first paragraph. It is difficult for people to read from there.
Dr. Kozlowska is referring to the first paragraph, and we are now displaying it in a large font. And there is a grammatical omission there in the last sentence. We apologize.
What is it? Is everybody capable of reading it? Oh, okay, fine. Because I did not. Yeah, thank you. Okay, so the second line or the second topic was define what is space normal for ISS 16 lunar and 3/8 Mars expedition. And I will tell you, we had very very hot discussion on this term, and they were like there were three conclusions or three points which we formulated. One was that actually, and we agreed, all of us agreed on this, that actually space normal, it is a term which doesn't have uniform, how to say in English, the understanding, the common understanding, yeah, because space normal, most of people in the group understood as the state which is normal as like for adaptation to space, and actually we never allow people to adapt to space to a full extent. And actually we support some state which is like in between of state normal for space and still normal for ground. But nevertheless, we decided that we will accept two understanding of this term, space normal, which is the state which we define when we have the person adapted to ISS life and work on ISS. The state for Martian expedition, and it means when he adapted already to being and working on Mars, and state when he adopted his life and work on Moon. And in this case, of course, the norm will be different for these three environments. First of all, because of level of gravity, which will be different in all these three situations. And but not only gravity, because we considered and we discussed also about possible differences in under this condition in radiation level and the environmental state and maybe some other factors which we don't know yet. But nevertheless, if we will take in account only the gravity level, it seems that the state on pure ISS and then will be worse than on Moon, and on ISS worse than on Moon worse than on Mars, because the gravity level increases a little bit from one to the other. But we consider also the possibility the space norm for these three conditions could be, I don't know who is the author of this term, because nobody of us liked it. But nevertheless, we even wanted to write down that this term should be explained when it is used, because the other understanding of this term was that maybe the author means that it is the norm which is enough to stay on ISS, or enough for requirements to land on Moon. I'm sorry to use, I don't know how to say on Moon what we are doing, to land, to decline to Moon, or state to decline or to land on Mars. In this case, actually, we have decided that the study should be an analysis of the environmental, what we know, what we predict about environment on Moon, or know a little bit, or predict on environment on Mars. The analysis should be done to build a model, and then we will be ready to say what will be the normal state for every one of the environment, or for to prepare to land for to every one of the environment. That is the second statement. Yes, Ashot. What is it there? The answer to the second question. Okay. All right. I'm sorry, because I don't see from here at all. I see a little bit here, but I'm not sure that I'm following it. Now, the third topic is define and standardize nutrition and metabolic requirements for physical homeostasis. Among us, we had not many, but two specialists on metabolism in space and so on, and they had given the answer that actually the nutrition and that should fit to metabolic requirements, which includes the requirements for normal living and performing exercises, and so on. No, not special requirements were added. I mean, there are some beliefs that we need some special ration which is rich with calcium, or some of cosmonaut believe that it should be, I don't know, some milk products and so on and so on. That the people who are specialists in nutrition and metabolism, they don't believe so. They believe that it should be just normal nutrition, which will cover all the metabolic needs in space and whenever. I mean, on Mars or on Moon. So the fourth one, determine factors essential to preservation of bone strength, muscle strength and integrity, sensory motor functions, and cardiovascular function. Our first answer was that actually to preserve the functional state of all the systems which are presented in the topic, they should be just the application of all the countermeasure methods and means which we are using on ISS station. The first of all of countermeasure, which should be different countermeasure for muscle, countermeasure for bone, and countermeasure for sensory motor, for keeping coordination intact, for orthostatic, for cardiovascular, and even special attention was given by people in the group to means and methods of preservation of psychological state of a subject, especially in long-term, in such a long-term flight as a flight exploratory. Nobody added anything because it said that determine factor essential to preservation. And it was not said that define or advance or wide, make more broad list of countermeasure or means to preserve this function. That was said determine factors. And main factors we do know, and we cannot add anything but the decrease in axial load and in load of support reaction forces, and decrease in loading, isolation, and sensory deprivation. And then later, when we discussed more and more factors were put on the table, and so this is the next line, which count all of them, because all of these factors can affect the function which we are talking about. Is it there? Mm-hmm. Okay. So, and the last one, develop required and standardized post-flight rehabilitation protocol and practices. And the members of the group, they said that the first of all, there was very hot discussion about necessity to have a standard protocol. More than that, some of the members of the group, they were talking about вредный, как сказать, вредный ашот. Вред. Detrimental. Yes, effect of standard protocol for rehabilitation as it is, because the individual state of different individuals is very different. Because in some people, they are most affected muscle and the other bones, in third sensory motor, and fourth, we have motion sickness and so on. And then we agreed later, after discussion, we agreed that actually there should be accepted some general protocol which count the methods which should be included, like physical exercises, psychological support, and means, and methods of physiotherapy, and so on. But we added to it that the protocol could be applied to an individual cosmonaut or astronaut after thorough investigation, which and then the protocol should be individualized in accordance with what was obtained. That's what was the results of our discussion in the group.
Nessa, with regard to the determining factors essential to preserving bone strength, muscle strength, etc., when I see the word factors, it tells me that we're going beyond basically a translational research focus down into more mechanistic types of studies. And is that really what was intended here? Or are you trying to determine an optimal prescription, if you will, for conserving bone, muscle, blah, blah, blah there?
Actually, we also discussed, you are right, because we discussed it as well, because it's like it allowed dual understanding, because if I talk about factors like some biomechanical or some factors of environments, then it is one thing. But the other, we were more thinking not about then factor and mechanism of their effects or affecting the system. But we were talking mostly about the prescription for different systems. You are right. But the prescription for the system cannot be done without understanding the factor and mechanism of its activity. So anyhow, finally it comes to the same understanding.
Yeah, but I think
that's why we were talking
in NASA directions now. They don't care about factors; they care about does it work.
No, I don't understand it, because I don't believe that it is possible to develop something sensible without understanding a factor and mechanism of the activity of this factor, of the influence of this factor on the organism.
You and I probably see it eye to eye, but I don't know if other people do.
No, I will tell you that we were 15 people sitting in the room, and everybody understood this way. Everybody. That's why when we discussed, like, we can just say that to keep all of the system, it is enough physical countermeasure, but that's not true, because when we know the nature of different disturbances which occur in space, then we know that the selection of mean and method should be different. If I don't know it, that's it. I don't know. I cannot work.
Well, I don't want to belabor this, but if you're going to understand what might work in terms of conserving muscle strength and integrity, it leads you to want to understand why, with unloading, you get atrophy.
Yes.
Okay?
Yes.
Now, from my...
First, I should find out that this withdrawal of support reaction brings this and this and this effect, and it is real factor.
But I have to tell you that there was a report by NASA called the SAT report that says we're not interested in why muscles atrophy. We're interested in how you stop the process without getting into the details of why muscles atrophy. And if my assumption here is not correct, I would like NASA to correct that for me.
Okay, I'm sorry. I'm sorry. I will tell you that I don't know. Very often I don't know how and what our Russian Space Agency formulates there. What they think.
And that's in bullet number 2, you make there's a statement about.
I don't hear. I'm sorry.
In bullet number 2, there's
Yes.
a statement about time frame for adaptation that varies between system.
Yes.
Would your group also consider to include that it also varies between individual? I think the point was made over the last 2 days that there's great variability between individuals when it comes to adaptation.
I'm sorry, but can you repeat? I'm very sorry, but can you repeat a little bit louder? Because combination of not not hear very well and with not understanding very well makes me completely lost. Just repeat it, please. Yeah.
And it's perhaps my accent. In the bullet number 2, there's a statement about time frame and for adaptation that varies between systems.
Yes. Yes.
Would your group also consider to include that it varies between individual, given that in the last 2 days there's been quite a few statements made that adaptation to space shows great variability between different astronauts, cosmonauts, as well as readaptation to the 1G environment also varies between.
Yes, that's what we meant. That and we even talked about. I just will not repeat because it was like exchange of opinion. We were discussing what is the difference of the requirements which are needed for readaptation of bone or for readaptation of cardiovascular, orthostatic deficiency, and so on. And definitely the mean and time of readaptation will be completely different for different subjects who are suffering. And we took in attention also that that actually the state of cosmonaut or astronaut is more variable after flight than in flight. In flight, you don't see so much difference if you don't apply special technique and so on. As after flight. After flight, you see very great divergence of effect. Some of people are completely, almost completely normal with muscular and bone system, but suffer very evident ataxia. They're atactic, they're discoordinated, they look like cerebellar patient. The other are very good in their abilities, coordination ability, but they lost a lot of muscle, which already show that this changes are not coupled. And orthostatic is something else. And vestibular, we heard today, it's completely certain group of people who suffer vestibular, the other not suffer at all. So that's why we said that the protocol of rehab should be like done in wide strike, like this. Different means of general rehabilitation should be used, like buses and so on and so on. But the protocol for every individual should be thoroughly individualized according to the very sorrowful proper test observations. Yeah. Again and again, we come to the same conclusion that actually, to be effective with cosmonauts should be interested that we will be effective with them, but for this we need very, very thoroughful investigation, to very thoroughly investigate them after flight, even if it takes time and efforts.
Thank you, Nancy. We'll go on to the next group.
Well, Dr. Alford, this is what you're getting when...
That's great. Oh, that's great.
You prohibited us from giving PowerPoint presentations, and my Easel XP computer just crashed, so...
Oh, okay. That's even better. That's even
At least it doesn't show the screen, so...
Okay, I would like to give you the report of group number 3. We had the theme Emerging Technologies and Applications to Fill Gaps in Space and Medicine. I think we were a very good team, great team, a diverse team, very focused and very creative. So the first thing, we more or less got rid of the agenda and the topics. So I'm not able to show you nice outline and answers to the questions that you have placed on the sheet. So we more or less involved ourselves in the brainstorming session and allowed just to come up with ideas and issues. And I think in the beginning we tried to set the stage and saying, okay, what are the gaps that we need to fill with technology later on? And in principle, we came up with 5 major topics. Topic number 1, and don't take me wrong here in terms of priority, we didn't prioritize them, we just give them in the order that they came up, is that usually the medical community is not involved in the technology and development. Usually we are presented with something we have to live with in the medical environment. As a result, we have to try to adapt our astronauts to be compatible with the technology available and not vice versa, to adapt the technology to best suit our medical needs in space. The second gap is that also the habitat where our astronauts are living in is not in our domain, not in our focus in space medicine. It's somebody else that is dealing with it. And certainly for long-duration space flights, we need a significant improvement. For example, there were some examples given that we have the exercise equipment and the toilet right next to the table where the crew is usually having their lunch and dinner. So that is certainly something which has to be remedied if we really go en route to Mars. Also, we have to understand basic and still basic medical and physiological changes. Currently, I think every physician even in a remote area has more tools, has more capabilities that we have, and has more understanding of the underlying physiological changes of their patients, which we don't even have. We have beautiful basic research that has been done and have good progress in basic medicine, but some essential elements like how does a normal blood look like and urine look like, we are missing it, besides other elements that we need to progress space medicine. There's another problem that we are lacking possibilities and being influential in putting cutting-edge technology in time onto the space station and being adaptive and responsive to problems that arise. And as a last point, we have to enhance our medical support capabilities to support injured and incapacitated crew members throughout the mission, but also upon their return, including the rehabilitation. So having set the stage and identifying those 5 key areas for that moment, for those 90 minutes of time we had, we then went through different aspects. And one of the key elements of some very sophisticated computer geeks in this room, including myself, liked to get the point across that this generation that is flying a long-duration mission is not us. It's maybe not even our children. It may even be the next generation, and they have grown up in an environment that is highly technology-driven. They have a much different and openness towards technology and software surrounding them, and it would be wrong to us using our understanding of technology and putting that already on the drawing board for the next generation space flyers. So we have to think out of the box and beyond, and have to look into possibilities to invest and implement software-driven technologies that support life and space medicine towards Mars. There's another big advantage to that. Currently, if we design medical hardware, we do that many years before it's even going to fly. So finally, when it's ready, the requirements may have changed. We may have gotten second thoughts. The whole design process, implementation process may have gone through different people because people are leaving, and so the handover may not work. So at the end, you're faced with a product that, if you're lucky, you can still use, but maybe not for the use that it was intentionally invented for. So diverting towards software-driven designs and getting rid of the dinosaurs of hardware and putting more embedded into a software design may also help us being more flexible and having more reliable and scalable facilities on board. Of course, the idea of the HAL 9000 computer crossed our mind. So for those, I guess everybody in this room knows Space Odyssey. So certainly there is certain risk involved, but there are certain people who mitigate also the software risk. So I'm confident that, and also depending on the company that's finally chosen to develop the software, you may not run into such big problems. Also, another notion that came up is that we also have to think differently in terms of instead of calling for a CT or MRI or name it that we know from terrestrial medicine, but looking into opportunities that certain hardware that's already on board or has been designed for a completely different application, if that may help us in using it for clinical applications. And a good example, for example, is the ultrasound that's currently on ISS that has been designed to fulfill scientific needs, but then has gradually been converted into a beautiful piece of equipment that we, on the clinical side, are now able to use for applications that nobody thought about in the times the equipment was defined. So in principle, we are looking into, and now again another language lesson for you guys, we have a German idiom that says, eine eierlegende Wollmilchsau. That means that you have an egg-producing wool milk pig. So you get everything. That's the term we're using, looking into equipment that is doing everything for all purposes. Of course, there will be limitations to it, but I think the proof of concept with the ultrasound shows us that we're on the right track. So this will lead also the crew en route to be more clinically autonomous and make, with the support of intelligent software and hardware that is usable for different applications, will make the crew more autonomous and finding diagnosis and treating. So in essence, to conclude this chapter of software-driven designs, is to use a slogan also from a computer company, but changing it a little bit. Think big, start small, but start now. because we need to start thinking about those technologies now if they have to be implemented in 15, 20, 25 years from now, at least to set the pace. Well, then finally we have the crew up there, and they may have some interesting equipment up there, but they have to deal with it. They have to maintain their expertise. They have to practice medicine. At least I would have a problem to being operated by a well-trained surgeon, but who hasn't been operating for 2 or 3 years. So how do we keep those individuals proficient? How do we support them in case they need to make a decision in a field that they are not trained on? So having, when time allows, a core database system in the background that may be terrestrial based, that provides the crew medical officer or whoever is on board with the appropriate knowledge that he can tap into, and then get the right answers, maybe supported by a flight surgeon team that's on the ground and is supporting the flight surgeon who is then finally executing medicine, is one important element. So to compile the space medicine knowledge and putting it into a database that is available to the crew, but also there needs to be some on-orbit resources. And again, I think for some reason the futuristic science fiction movies have something to it. You know, the holodeck is something which is certainly something. I think we now call it human patient simulators, but holodeck to experience and to experiment certain therapy procedures to evaluate if you're running out of your resources, if you apply a certain therapeutical strategy, or if you could you use another pathway, get the same result, but being a more resourceful. Those are things I think we have to implement and think about. Next topic is certainly where we have to think more about personalized. Yeah, I don't know which view chart we are on, because we maybe just forget about it. Because I reorganized a little bit the order, but thank you anyhow. Is to think about personalized medicine. I think that was a theme that was coming across several of the panels we had those 2 days, that flying into space and the reaction to the space environment is a very personal issue, and the reaction is to some degree similar to the individuals, but very often we find very individual responses to spaceflight. So it seems to be natural to be more personalized in terms of providing drugs, providing rehabilitation programs, countermeasure programs, etc. And of course, there are new technologies that are rising, like biomarkers, and genomic research may help us tremendously, not again in selecting in or out specific space flyers, but to be more specific in the medical support that's supplied. In this whole domain of personalized medicine and the personalized environment that we have to offer to the astronauts is also one important aspect, to provide them sufficient intellectual stimuli, or as some of us put it, in a more cognitive-rich environment. So to distract people, to motivate people, to use software again, to do some mental training and exercise, mental exercise. And last but not least, to provide a habitat that, in difference to what we currently do, we are providing a habitat that provides survivability. But we have to provide a habitat that provides working and living in space for an extended period of time. And I think that's clearly our domain, be it medicine itself or be it our psychological support team. But certainly, as we outlined, the habitat itself is a key element for crew survivability in the long run, and the status of mental and physical fitness of the crew. So we have to invest more in this area. Another important aspect, even though I know that many of the agencies are to one or the other degree involved in that, is to also close the gap between life sciences and medical operations. There has been good reason why we have been separated for a long period of time. But if we don't learn from each other, if we don't learn from the results that life sciences has brought, processes, hardware, procedures, data, where we as space physicians can rely on, we don't move forward, and vice versa. If we don't give stimulus to the life scientists to say, hey, we have this problem, please give us a result in 3 years or 4 years, we need to have this and that countermeasure process in place by that time, we also don't move forward. So there needs to be much more interaction between those two entities, and still preserving, of course, the scientific, let's say, confidentiality or the right to publish, to do science in a scientific way. On the other side, maintaining confidentiality of the medical operations data of the individuals. This is a tough thing to do, but I think we have to tackle that problem. Last point, which I think it's nothing agency specific, NASA specific, I think it's government agency specific, is that, and it's a evolutionary aspect, I think, is that certain agency policies and processes are in such a way that they in principle prevent us from doing our job. And if there is not a big change in mentality in our government-driven space agencies, wherever we are looking, those 5 partners at least, we also won't move forward. I think the key element in the 60s was that at that time, of course, there was a space race, but of course also the agencies was not having an overhead of formalisms, protocols, etc. at that time, and that made the people move in getting to the moon in a very short period of time. Now I think we know too much, and we prevent ourselves from moving forward just because we have to always think, okay, is that appropriate? Does that fulfill requirement ABC? Which form sheet do I have to fill out to get this and that? So I think that is a big showstopper in many areas, and this is something that needs to be remedied. Let me just have a last look, and I think the major theme at the end that we came up with summarizing the problems that we are currently facing to further develop space medicine is that we are seeing a design-driven policy. We are always confronted with a ready design, and just look at this beautiful, nice video-embedded PowerPoint presentation of last night, but everything is fixed. No, there is already a rocket, there is design, and they, at the end, put 2 people on top of the rocket. But have we been involved as a space medicine community to an extent that we believe we should be? I don't think so. I think we have to move from a design-driven policy to a policy-driven design, and I think that was the key message that our group finalized and embedded as a quintessence of the discussion topics that we touched upon. That's the summary of group number 3. Thank you. Any questions? We were so good that there are no questions? Good.
Very good. With the chair's prerogative here of this, we'll keep the idea of having further discussion at the end and put a lot of this together from the groups.
Well, thank you. I stepped in for Leroy Chow this afternoon, and we didn't have view graphs or flip charts or presentations, so I'll just hold up my handheld notes here, and I'll follow along. Actually, we do, but I have no idea how to connect this to the back screen. I don't know if anyone's back there. I think we can project it, actually, if someone can project back there. There it is. Okay. Good. We had an interesting topic, and it actually broadened out somewhat in that the challenge was to look at ISS as a collaborative test bed, but also a future lunar lab. So we had to make one immediate extrapolation that there would be a lunar lab, in other words, where the architecture on the lunar surface would need to be broadened, and the development is not that far along yet in terms of the lunar architecture, but we assumed for today's discussion and purposes that it was. So what we did, much like Group 3, is although we followed the rules of the presentation, is that we brainstormed first and then kind of closed with some next steps, and we tried not to be proscriptive about the next steps, but we had a couple of good ideas about how we might follow up. So the premise was that two things going in up front is that the ISS is really good for Mars transit, and the lunar surface is good for a Mars surface development. I think that's already been expressed. But it's good as we go forward to probably separate those two ideas. So unfortunately, this group also had me as the facilitator, so that since we're so focused at NASA and standards to deliverables, you'll see a nice flow down from that. I guess I can't get that out of my head. So what could we use ISS for as a test bed? Well, first would be standards, and this was fairly easy because we are working on an ISS medical project right now. And thank goodness I didn't put spaceflight normals in here. I almost did, but it was a point well taken from Dr. Kozlovskaya, because we have been using that term a bit, and you'll see it here. It means serial in-flight measures, and it's more to characterize the current state. So we probably need to look at that term. We've been using space normals a bit casually because there are different states we need to characterize. But yet that's still the idea that if we can get in-flight serial measurements on the ISS and a whole variety of physiological systems, we can perhaps better characterize those systems as we move forward. We have many standards in development right now. We have cardiovascular standards, musculoskeletal standards. We have exposure standards already for radiation, air, water quality. So the ISS is a great test bed for that. We have a microgravity environment. If we can put the right protocols in place and collect the right data, here's a golden opportunity. Also was brought up in the discussion of space pharmacology. We really don't know much about dosing of medications, absorption, the route that should be offered, and what the outcome would be. So we, for many, many years, have talked about different applications, intramuscular, nasal administration of drugs, because there's some thought that at least the GI absorption is not exactly the same on Earth, at least in the early days. But we really don't know. We really don't know what the volume of distribution of medications is, and that would be important. And then we said, well, if we have an ISS medical program, why don't we start thinking about a lunar medical program? Start it now. We sort of backed in to an ISS medical program when the research for going to the moon and Mars became very focused for exploration. Before it had been very open. It had been using ISS as a national lab, and when we had switched to exploration, it became very focused on going back to the moon and Mars. So we've had to retrofit a bit and come back with an ISS medical project. Well, we can be thinking about a lunar medical project now with the idea of going on to Mars, because that is going to be a sequence of focused operational missions that will go forward. So that was a good idea, I think, from this afternoon. So then we flowed down to requirements, because one of our challenges was what were the technologies or the research that could go on in ISS. I really talked in that first bullet about more of the research that would go on about the human being. So what sort of technology development might we look at? Two of the big ones, of course, are for environmental control, life support systems, air monitors, water quality monitors. That's going on right now. The idea there is we have certain operational hardware on the ISS that we have validated and would use for making operational decisions, but we could also put developmental hardware on board If it did well, perhaps you could use it down in the future. But for right now, it's just a proof of concept. And I will tell you, we had a discussion. I think I have another bullet later on, so I'm probably jumping ahead. But when you think about new technology developments and that we might not purchase a piece of hardware for many, many years, we still thought it was useful to go ahead and use the ISS as a test bed, because perhaps we would employ the 4th generation of that piece of hardware when we went to the moon. But we should get started now and validate that hardware in space. So it's a little bit of a combination between waiting later till you can deploy the most current technology versus getting started now and getting this process underway. So there will be a blend here of process and technology, because there already are lessons learned emerging from the International Space Station that we can pursue. And some are just process driven. So inventory management. Can we come up with better systems so we know where the hardware is when hardware swaps in and out, when our food storage? That'll be pretty important to us in the future, especially if crews are going to become more autonomous and they will be self-sufficient. They'll need to know exactly where materials are and what they have available to perhaps put unique applications together. Maintenance toolkits. We have a fairly high, and this is more for development. This isn't flying a new maintenance toolkit. This is trying to learn, how do we do maintenance better? How do we make hardware more accessible? We've repaired some hardware in orbit we had no intention of ever doing maintenance on. We talked about the volatile organics analyzer, or Bill Gerstenmaier did the other day. That piece of hardware was never designed to be taken apart and repaired, yet it was. So we've proven that crews can be adaptable and flexible, can get procedures uplinked, and go through a process. Can we do that better? Can we anticipate that, and can we put better tools and processes together for the crews to repair? We certainly have had a very high overhead of time with maintenance of our hardware, so can we reduce that? We've talked about efficiencies of maintenance, efficiencies of our countermeasures, because the hours that we return to the program we can deploy and use for other products. Let's see if I can scroll down here. Can we scroll down the screen a bit? There we go. Okay. Put the requirements at the top. Human factors interfaces. You know, the comment was made, why does Apple do so well? Because they have great, the person's opinion was they had great interfaces, like with the iPod. So can we experiment with that better? We don't often do a very good job of simplified interfaces, how to use pieces of equipment, make things simpler. We talked about consumables management. Can you make your own consumables? In other words, we've talked in years past about taking potable water, making it into sterile water. We even talked a little bit about growing your own food and such. So can you come up with processes to make your own consumables? In terms of the ISS and lunar test bed there, we may have some of these bullets a little out of order because we're kind of quickly taking these off of flip charts. But on the ISS, one of the ideas is, can we intentionally expose equipment as a validation measure? In other words, we'll have capabilities to put hardware outside for exposure to microgravity, for exposure to the radiation environment. Can we just employ that as we fly these new technologies, especially if they're designed to be used in a vacuum and maybe envisioned to be used outside on the lunar surface? So the ISS can also take that one step forward then and intentionally expose equipment to the fairly harsh environment. Fairly good discussion around simulations and scenarios. You know, we talk a lot about the current missions, what's coming down the line, and that's true. We do have a very organized set of exploration missions coming in front of us, and so being able to anticipate those and perhaps to create some scenarios for planning might be very beneficial. So, for instance, can we use the ISS to stimulate a 6-month transit to Mars and then have a landing scenario or have a communications scenario? We talked a little bit about telehealth being a problem on Mars with the 40-minute round-trip communication delay. Why don't we run some scenarios and just build in the delay and see what happens. We can plan simulations on ISS to try out Mars-based protocols. The concept had come up already. It's been raised by a number of folks about returning crews and putting them in some sort of Mars scenario, being isolated, communication time lag, just to see how crews operate, what are the issues, what really comes out of that. We talked a lot about boredom and planned time. That I think Dr. Otto mentioned that as well, and others, that there will be these cycles perhaps of where the day is not that filled up, and it's important to have meaningful activities and meaningful work for the crews for these long periods of time. What are the support procedures necessary, behavioral health support procedures for the crews under duress? And do we, when we have those kinds of interactions, do we also adequately debrief the family and spouses as part of that support unit? Is that something else we can look at? Could you go ahead and scroll down a little bit more? Under operations, we talked about inventory management already. There was a lot of discussion about skill development and maintenance. Skill maintenance, of course, that goes on now with docking procedures that the Russian side trains. I think if I got that right, it was about every 2 weeks to stay proficient. So what other things do we need to maintain for skill maintenance? If we're going to have crews going to Mars, we're going to have medical officers going to Mars, we can experiment with that now. What's the right level of simulation for a medical officer to maintain his or her skills? We also talked about skill development, real time. In other words, can you acquire new skills in orbit? We already have some suggestions that yes, you can. We've had to do some new EVA procedures that weren't anticipated before the flight. But the generic training was good enough that the aspects of the training could be customized, cut and pasted, if you would, into a new procedure or modified procedure to go do an EVA. Can we do that with other things? And can we acquire completely new skills? I'll go back to the repair of the VOA. Jeannie's folks, the biomedical engineers, worked up the procedures. I think that was 54 pages long or some. It was a fairly staggering length of procedure. And yet it worked just fine, and the VOA was repaired. And so how do we do that in a planned way and make procedures perhaps simpler, more customizable across hardware? And finally, contingency protocols. Can we either pretend or simulate intentional failures? Let's fail some hardware, fail some of our components. For instance, we talked about if all the exercise hardware failed. And a few years ago, that wasn't such a far-fetched idea. About 4 years ago, we were perhaps looking at that on ISS. What's your fallback? Is a pharmacological treatment acceptable? For instance, would bisphosphonates be a second-order treatment that you'd like to understand and have in place, whether or not the mission required it? If you lost all the hardware, could not exercise for some reason, could you maintain some of the systems through a pharmacological treatment? It's just an idea. But are there second and third order protocols perhaps that we should be thinking about? Let's see, the international training model, that idea had to do with, this panel was about international collaboration. Can there be a coming together of standards, of procedures? The short answer, I believe, is yes. We talked about the multilateral groups that work together in the medical environment. We have a very good coming together of our understanding of medical certification. We're beginning to merge our ideas about medical treatment. Can that also apply to pharmacies that we would fly and continue to refine that process? Can in the future we go in with joint standards that are developed, whether for medicine, environmental? You know, we have worked into that through the ISS, but we didn't start there. We had our own unique standards. Could you go ahead and scroll down some more? A big discussion on ISS lessons learned. Yeah, if you can stop right there. And this would really come under the heading of knowledge management. Can we do a better job with capturing the lessons that are emerging right now and not only making sure they're communicated amongst ourselves, but preserving them for the next generation coming along, or the next set of designers, or for the next set of vehicles going on. There are a lot of things we've learned on the ground and in flight that we capture more or less. We capture them within our own working groups, but do we get them out to a broader community, and do we get them out throughout the spaceflight community? So a knowledge capture environment would be very important. We talked a lot about human performance model for health and behavior. At present, we can only think of one study that's going on crew interaction and performance. Can we provide more of those on orbit? I mentioned multinational approaches to nutrition and pharmaceuticals. If we're going to fly multinational crews, and I believe we will, then can we look at that, because we may be very constrained in terms of the diet? Is there an acceptable multinational approach to the nutrition, to the pharmaceuticals that we fly to treat? We already talked about simulations again, but here's more focused for simulated medical events on ISS. Again, tailored terrestrial approaches, alternate applications. Ultrasounds come up several times. Are there others? Can we start deliberately looking at pieces of equipment that perhaps are easier to fly than their Earth-based counterpart, but would provide us perhaps the same amount of information if we do the right comparative studies? Scenario-based planning again came up. So those were more or less the themes. So what we talked about then, if we can scroll up to the next steps. How to get started. So first off, we thought about establishing a coordinating mechanism. And actually there were a couple of comments made afterwards that perhaps a follow-on from this forum could be forums to address some of these collaborative alternatives. So for instance, this task was defined as collaborative utilization of the ISS and technologies. First off would be a fairly rigorous study of that to determine what does that mean. You know, we had an hour and 15 minutes to write down the things we could think about, but I'm sure we missed some, and we were already diverging into areas not in space medicine. So that shows you there's a healthy understanding of what the opportunities would be on ISS. So it would be good to capture that, capture what are the opportunities for this collaboration, and get all those topics down in one place. Scenario-based planning would be, we think, very important. What lunar and Mars scenarios do we see as important that the ISS can help flesh out, that can help run the simulations and understand what the outcomes might be in a scenario on the moon or Mars surface? Identify the stakeholders, government, university, private. You know, we're talking a lot about COTS hardware. We are trying to partner strategically with organizations early on to see where new technologies are emerging. Our feeling right now is that we will most likely be employing technologies developed by someone else rather than technologies that we developed. So how do we do a better job of that? How do we partner with companies or folks that are doing a good job? The whole idea of certification of flight hardware. That's a fairly lengthy process. How do we do better with that? How do we get COTS hardware on orbit faster? Whatever we solve for the ISS will certainly only benefit Moon and Mars. So as we do develop new technologies, how do we deploy them at a more rapid rate? Now, again, not compromising safety, but can we modify our approaches? We're trying that internally. We're proposing to fly an AED, a defibrillator, and also a new treadmill, which is a COTS piece of hardware. So the idea of how do we identify, certify, get upstairs much faster. Techniques and processes. Those are their remote, and those that would have to be performed. Actually, Dave, you might want to speak to this one because I was hurrying here at the end. But it was about either techniques or processes that we had on hand that were remote or on hand with the ISS. Using ISS as a technology accelerator, we've pretty well talked to that. Flying prototypes early. I already mentioned that earlier in the talk where even though we might not have a need for the piece of technology till 2020, fly it early, fly it now, see if we can modify that for space flight and buy the second or third generation down the road. Knowledge capture tools we thought would be very important, multinational processes, and an ability for sustainable resupply. So those were the areas we captured out of the flip charts that we thought might be captured under a follow-on discussion of how we can collaborate using the ISS, and maybe that can be assigned out for a further work. And how would that happen? Well, we have current multilateral panels. We have 3 medical panels. We have joint working groups for research. We have the International Space Life Sciences Working Group. So for the ISS, we have working groups that we can perhaps challenge with this information to move that forward. Carl mentioned the global exploration. I've forgotten what the acronym was for. It's always a danger writing a new one down that you don't deploy. But it's the group that is pulling countries together to talk about exploration. If they so chose, they might decide to have a linkage back to the ISS collaborative groups that are already well established and functioning, and at least perhaps these groups could act as advisors to this exploration group to talk about lessons learned, what works, what worked, what didn't work, what would we hope have worked on ISS, and kind of maybe make that collaborative process easier. So I'll stop there and see if there are any questions, comments.
Jeff, are you proposing we did this before, we had those DSOs where we flew hardware to test it out to see if it worked. And we were doing that on shuttle, so we were able to bring the hardware back and look at it. Are you proposing setting up a program like that so that we can have testing of medical hardware for the lunar base, but using the ISS as a test bed?
Yes, essentially where that makes sense. There is an air monitor. There's actually 2 or 3 in work right now, funded by exploration, that will fly on ISS as a test bed. So that's already underway, and I think we can expand that. Ultimately, yeah, you'd want to bring them back for the engineering analysis. I think there was,
Yeah, Jeff, unless I missed it, you skipped over bullet 5, which is task analysis of lunar surface.
Oh, I'm sorry. Yeah, that was important to be in this document, and it's not just pure task, say, related to EVA, but it was more, again, scenario-based planning. What are the tasks you're going to do on the lunar surface, and for how long, and of those, what would make sense to simulate in the ISS, perhaps?
Thanks.
So a lot of those would be components of a document, perhaps, or a study group. We're just proposing to throw these out as major topics that we identified. Other comments or questions? Okay, thanks very much.
I think those group discussions were very productive, and they offer a lot of other perspectives in terms of a lot of the discussions we've had today and yesterday. I get the sense that you've had enough. All right. Remember, we have a reception and dinner beginning at 6 o'clock, so you have a little bit of time to get your brain clear of other things. Yes, Victor?
I just wanted to make, since this is at the end and not in the middle, a clarification of the question that was asked earlier. NASA has no policy against doing fundamental or mechanistic research, and in fact continues to fund such studies in Carl Waltz's Advanced Capability Division. And if there's any specific questions or additional information needed, I'd be happy to talk about it offline.
Thank you, Victor. All right. Well, we'll see you in the evening and for dinner, and then we'll have a great session in the morning to wrap up. Good. Thank you.